And I wanted to thank Mr. Botticelli for coming down to my district in the Tampa Bay area when he was the drug czar about a couple of years ago. It was very informative, the forum we had, so I appreciate it very much. Also, I want to ask some questions on the lock-in. I know we've covered it a little bit, but I have a couple bills with regard to that. So I want to start with Mr. Douglas, if that's okay. Yesterday, CMS talked about the importance of lock-in as a tool to manage prescription drug abuse and Medicare Advantage and Medicare Part D. Lock-in is not new and has been used for years in Medicaid and commercial insurance. Since you run a Medicaid managed care plan, you might be able to talk about how lock-in programs operate and what you've seen. Does your plan run a Medicaid lock-in program? And if so, can you tell me how you structure the program and what triggers you're looking for in identifying an at-risk beneficiary, please? Thank you.
So yes, as you said, lock-in programs have been around for a long time, both in state, from a state agency as well as from managed care programs. And Centene in our states, we have over 10 states where we do have lock-in programs. We work in partnership with the Medicaid agency to structure and be able to create the policies and procedures. There is no I'd say one size fits all approach to lock-in programs. In some states, the lock-in is around the prescriber. In other cases, it's about lock-in to a pharmacy. So there's different, or it could be both, prescriber and pharmacy being locked in and having the member have one prescriber and one pharmacy. So it varies. Now, there are triggers in terms of the types of utilization, looking at how, for example, in one criteria I'll go through, there's looking at using 3 or more pharmacies within a 30-day period. 3 or more prescribers within a 30-day period become triggers. Utilizing 5 or more controlled substances in a 30-day period, different drug classes. So we look at all different types of triggers and create that policy. In many cases, the pharmacy board is part of the process too, to make sure that they're integrated into the policy development along with the Medicaid agency. We then also, before we do the lock-in, there are notices sent out to members, notices sent out to prescribers in the pharmacies, so everyone is on board and understands the new process that's in place. We have found this to be very effective. Again, this isn't, you need to cast the net appropriately, and that's where having the right triggers and knowing who that you're bringing into the program, so you're not inappropriately restricting access to needed services. But we're done, and we have some evidence and data that's shown that we've been able to bend the cost curve and be able to still provide the right outcomes in these lock-in programs.
Mr. Srivatova, do you want to elaborate? I know you answered that question when Mr. Guthrie asked you that question, but do you want to elaborate as to the triggers? Sure. How do you identify the at-risk beneficiaries?
So absolutely. Just to add on what I said previously, so we operate 2 plans in Florida and in Massachusetts today, where we have a lock-in in place on Medicaid, and we see kind of expanding that into Medicare Advantage in 2019. This is really, it's a community-based outreach effort to do lock-in effectively. So it's engaging with the individual. Each state has different criteria as it relates to Medicaid, and so we're kind of following the state's guidelines and trying to be coordinated. But it's coordinating with the individual and coordinating with primary care as well as specialty care. And in a lot of these cases, these are individuals with physical health and as well as comorbid behavioral health issues. And so as a result, we're working with community-based mental health centers as well to be able to have a coordinated approach towards a lock-in related to a prescriber at a location so that we can kind of reduce overuse or misuse of drugs. But I think that another key element is simply making sure that we have care management wrapped around that, as well as in-home services, peer supports, and access to telebehavioral health and telehealth services as well to make sure there's a coordination of care. So,
How effective has the program been?
so we've seen it's been effective in Florida from our perspective in your area, and we've been able to see kind of increased, reduced utilization and stability in terms of outcomes. So the recidivism or kind of admissions and readmissions related to things have gone down.
Mr. Douglas, how effective has the program been?
Again, we're very effective, that we've seen a reduction in costs, overutilization primarily from pharmacy spend, but also on the medical side as well, from inpatient as well as emergency room. So when done right, it's been very effective.
Okay, very good. I'll yield back, Mr. Chairman. Appreciate it.
Gentlemen,